It's likely not a coincidence that you're here looking for effective information about the low-carb or ketogenic lifestyles or a carnivorous lifestyle. Are you looking for trustworthy information on healthy nutrition, weight loss, general health questions, balancing your hormones, or living a longer, fuller, or more abundant life? Even men and women at the peak of health find themselves wondering if there's more to life beyond the mirror, the scale, the stress test, the colonoscopy, or the lab test. Whether you're looking for more meaning in your life, increasing your confidence, your ability to make a bigger impact, improving healthy relationships, improving your wealth, experiencing deeper and more meaningful love, or even creating a powerful, lasting legacy. Find out how amazing your life can be on this episode of Doc Talk with Dr. Adam Nally. Listen and learn as we take complex health topics and make them clear, understandable, and applicable to your life. My desire is that you find the answers to the burning questions you have, answers that will get you back on track, improve your health, and let you be who you were meant to be. Whatever your reason, thank you for being here. I'm so glad you're joining me today. If you have a question that you'd like discussed on Doc Talk, I'd love to answer it. I cannot give individual advice or recommendations, but we can answer the question in an educational format and give you some tools to make educated decisions about your health. If you have a question, email it to questions@docmuscles.com. Again, that's questions@docmuscles.com, docmuscles.com. If you're interested in more personal instruction and information on any of the topics discussed here, go to docmuscles.com/membership to learn more and sign up to be a part of my health and coaching services. It only takes a couple of minutes to learn more about your health. Again, that's docmuscles.com/membership. Enjoy the episode of Doc Talk with me, Dr. Adam Nally. We're going to talk about women's brains and men's brain a little bit, premenopause, perimenopause, and menopause, and how those relate to dementia. So, like I said, if you have questions, stop me. We'll dive through this, and there's some new information that we've added since our last one, so we'll be able to talk about that. So, anyway, we'll dive right in. Before we get started, it's important that you know that all of the information we talk about in this video can be found in my new book, The Menopausal Survival Guide. It's currently available on Kindle and as a PDF download on my website at docmuscles.com. Check it out there. So testosterone and estrogen shape the brain of both men and women. In the brain of men, at day 21, the X and Y chromosome begin to produce testosterone in the male fetus. And the interesting thing that's there is that fetus is then pickled in testosterone for about 7 months. And so as the baby is developing in the uterus, you'll see that testosterone is flooded. In fact, the testosterone level in the fetus is at the level of a normal adult. And this is why when a baby is born, a male baby is born, their testicles are actually disproportionate in the size, in regards to their bodies, because of this pickling. My wife was shocked when her son was born and went, "Why are his testicles so big?" And it's because he's basically been pickled in testosterone for 7 months or so. Now there is literally a grown man's level of testosterone in that newborn boy's body, and that's why men act the way they act when they're children, or I should say, boys act the way they act. Now, in estrogen and testosterone shape the brain of the female as well. And at day 21, the two X chromosomes begin producing an increased level of estrogen in the female fetus. The female fetus and newborn is pickled in estrogen for 9 months in uterus. And then for an additional 2 years, that estrogen level is really, really high. And that's why you'll see breast buds in the female baby over a period of a couple of years. So maybe you may have wondered why do the babies have these little breast buds, or these little their areolas are a little bulging. That's because they're basically being pickled in estrogen to help their brains form. So testosterone and estrogen are essential to brain formation and brain function, and that's going to relate to later in life where we talk about here as we go. So something to understand. So there's a grown woman's level of estrogen in that newborn baby girl. So if you have children or grandchildren, you can understand that her estrogen level is that of a female woman, and the man's is that of a male adult. Questions about that? All right. Testosterone differentiates both men and women. In the male, that testosterone causes brain compartmentalization during development. So it changes the way he thinks. And so he will think about one thing at a time. He'll be single focused. And that process. So if you walk up to a man while he's watching television, he may not hear you unless you get his attention, because his brain with the high level of testosterone is designed to be focused singly. And that's why you hear men can only have like a one-track mind, or you'll hear them say that. This provides for a brain with the ability to hyper-focus on one thing at a time. Some people estimate this was related to the man's ability to sit in a tree or in the forest and hunt and focus on that one elk or that one deer that he's hunting at a time. That's different than females, which we'll see in a minute. It also gives the men capacity to see very high speed in motion. So men actually have the capacity to see motion more effectively than women, and that's because of a high level of testosterone. That's why men are interested in fast-moving things. They see them and they can observe them more effectively. It allows men to screen out everything else except a specific object. And to my wife's detriment, at times she hates this, but it's actually a part of the testosterone in the brain. Now, the young girl up to age 3 has normal female levels of estrogen, and it's what makes the young female girl actually so enchanting. That high level of estrogen makes her very enchanting to both men and women. It causes what's called diffuse awareness. It allows her to be aware of multiple things at multiple times. In fact, I've heard some women and speakers talk about it's why women think that inanimate objects can scream at them. If the pillow's out of place, it'll tell them, I'm out of place. Not actually in words per se, but it will let her know it's not in the correct place. It's why women will walk into a room and they can't focus on one thing because other things may appear disordered. And it's because of their ability to see this diffuse awareness. If you look at the caveman times, people suspect that it may have been when they were looking for food and they were gatherers, and so they could see a field and know where the berries were at, where the ripe ones and where they were not, if that makes it simple to understand. But it allows for that diffuse awareness. Where men are very single focused, the estrogen helps for diffuse awareness in a woman. This also allows a woman to perceive the needs of everyone in the room at the same time. It allows them to be mothers in this capacity, and so they can have 2 or 3 or 5 children and know what the needs are of those children and their husband at the same time. And it can be that can be a blessing and a curse at the same time, I've been told. I'm not female, I don't have that capacity, but my wife tells me it is a blessing and a curse. Questions about that at all?
No.
All right, very good. Okay. Let me just make sure we've got everybody here. I think we got everybody in. Okay, fantastic. Now, all right. So if we look at the premenopausal phase of life, during the phase of life when a woman starts her menstrual cycle, and that's usually sometime between 12 and 15, and then through the age of roughly 55 or even 45 to 55, every month she's going to have a cycle, and there's going to be a cycle. So what happens is one of the eggs in an ovary is released, and that egg is a growing follicle, and that follicle grows as estrogen and FSH rises. So estrogen is going to rise. That follicle is growing. Then that follicle will be released, and that's the actual egg. And at the release, it's released as estrogen suddenly falls, and then progesterone begins to rise. Progesterone is the purple line, and estrogen is the yellow line here. You'll see that right about 14 days period in most women. Some are earlier, some are later, depends on how long their cycle is, whether it's 28 days or 30. Then that progesterone will spike, and the spiking of the progesterone will actually cause growth and development of the lining of the uterus, so that if an egg is implanted, that egg can implant right here, and I put an egg there, so that follicle can drop in there and implant. And if the egg is fertilized, then a fetus begins to grow. As that progesterone begins to fall, then the lining begins to break down, and as estrogen rises, what will happen is that lining will slough off and bleed. And so the bleeding occurs during this first phase here, where estrogen begins to rise and FSH is up, and then there's a spike of luteinizing hormone, which causes the estrogen to drop, causes progesterone to kick in, and then that progesterone the cycle will repeat. And then in the average woman, it's roughly 28 days. It can be shorter or longer in some women. If these hormones are off, that cycle will not be correct. And so one of the things we deal with in the office is the cycle correct? And are you producing enough progesterone? Are you producing enough estrogen or estradiol to help the cycle work? And so that's important to understand in that regard. Now, progesterone is converted into hormones that make cortisol. So if you are under high stress, you actually will pull more of your progesterone into cortisol, and you won't actually, and those women who are under tremendous stress or who are really, really physically active in their uh, time of premenopause, they may not have a correct cycle if they're exercising too heavily, because they actually will pull from the progesterone into cortisol. So just something to understand. One of the factors that plays a role with abnormal periods or abnormal changes that way. This is just another picture of the cycle here. So cycle roughly 28 days. Your follicular phase is here as estrogen's rising and peaking, and when estrogen falls, you'll see a rise in progesterone. So the bleeding, a female menstrual cycle or bleeding will occur in the first 7 days, and then as the estrogen reaches its peak, then it's going to drop. In reality, it should drop right here. This is wrong, and then the progesterone will rise and stabilize the uterus to thicken up the lining and prepare for the repeat of the cycle. Testosterone in women runs at a fairly low level, and then it'll peak right here around the time of ovulation, and then it drops back down to normal again. So something to understand there. All right. Now, as a female moves through the process of her hormones changing, you're going to notice we notice this decline, and the first decline we see is there's a decline in estrogen right here. Around age 45, we'll see a fairly notable decline in the height of her estrogen. We'll see a notable decline in her progesterone here as well. For whatever reason, I actually see a decline in progesterone more frequently than I see estrogen, and sooner than this in a lot of women. And my suspicion is that that's related to our diet. And the level of xenoestrogen exposure we have. So a lot of the foods and things that we use, dryer sheets, plastics, a number of things like that will keep this estrogen staying higher, and we'll see the progesterone drop sooner than this, than the average normal that we would see. And you'll see these hormones drop. FSH and LH are two hormones here that allow for that fluctuating. As a woman goes into menopause, we'll see a rise in that FSH, and then as both the estrogen and progesterone drop off and the ovaries kind of peter out, we'll see them all fall down. Now, testosterone is not here. What I commonly see is testosterone also follows this pattern with estrogen, and then around age 55, it begins to tank off and teeter off, if that makes sense. So there's this. You don't need to really know that, but I just want you to see that traditionally you're going to see around somewhere between ages 35 and 45 a dropping of these hormones, and a lot of women see a dropping of progesterone first in their early 30s, and it throws the cycle off and makes them more moody, have trouble with sleep, trouble with concentration, even hair growth and wrinkles and gray hair. All those things occur as progesterone starts to drop sooner than estrogen. So one of the reasons to look closely at those. So the medical definition of the change is, so premenopause is any age during which childbearing is possible. So usually that's somewhere between 12 and 55. Or 45, depending on how soon that drops. Perimenopause is where the menses begin to become irregular and inconsistent. Trying to turn the phone off here. So the period may be heavier or lighter. There may be cramping. There may be bleeding. Heavier or lighter bleeding, I should say. You may see you miss a cycle here or there, and it can be more progressive or it can be erratic. You may experience hot flashes during this perimenopausal period while you're still having hormones or you're still having periods, but the hot flashes kick in. You can see mood changes and cognitive changes. Often this starts to occur somewhere around around 45, but a lot of in the last 10 years, I've noticed that this is happening in many women in their late 30s and early 40s. The average age for this is 47 around the globe, but it's actually sooner in most of the women I see in my office. And again, I think this is related to diet, stress, and exposures to various things that we eat. This transition can last about 4 to 8 years. In some women, it can last up to 14 years. It just depends on how soon those hormones drop off in that regard. So menopause is defined as a 12-month period after your last period. So you'll go through perimenopause, and it may last anywhere from 4 to 12 years. If you've gone for 12 months and not had a period, then you're considered in menopause. Now, if for some reason at month 11 you have a period, you start the perimenopause clock over again, and that happens. Lucky you. Postmenopause is 12 months after your last period, and you're considered postmenopausal. Now, there are some women that their hot flashes stop, or they don't have hot flashes. Other women have significant hot flashes that may last for anywhere from a year to 10 years after postmenopause. That really depends on what your hormones are doing. And that's important in regards to what may be happening to your brain function and your vascular disease. And we'll talk about that. That's why I brought this up and why it's important. So if you go through perimenopause for 12 months without a period, you're considered to be in menopause. But if you suddenly have a menstrual period, then congratulations, the clock resets and you're now perimenopausal again. Questions about any of that at all?
Dr. Nally, I have a question.
Yes, ask away. Go ahead, Sarah.
I'm sure all of that is totally different with PCOS.
So PCOS means that you have abnormal progesterone and high testosterone starting somewhere in your 20s all the way to your 40s. And that's going to throw off the way you cycle. It's going to throw off the frequency with which you form ovulation and the number of follicles and cysts that may form around the ovaries. So that it gets thrown off. Is that answering your question?
Kind of. So I know it makes everything all like a mess.
It does. Yes, it does.
Does that make the PCOS part like the perimenopausal? I don't remember the right word for that. Right before menopausal?
Most women with PCOS, if they don't treat it, will actually feel much, much better when they're in perimenopause. A lot of them will see earlier perimenopause than normal. I commonly see women go in their 40s, see those hormones start to shift and change in that regard. It doesn't change the definitions of perimenopause or menopause. It's just that their menses are different. You may see differences in those because of what's happening, if that makes sense. Did that answer your question, Sarah?
Kind of. I've had the ablation, so it's tough for me to track cycles.
So if you had ablation, that throws everything out. And the only way to know where you're at is if you actually test the hormones. You may see mood changes, you may see changes in skin tone or cognition, but the only way to really know if you've had an ablation is to actually test the hormones.
Okay, yeah, it's hard to tell. Is it bad to go early into menopause?
No, it's not bad, not bad at all. I have women that have gone into perimenopause at 37, and been in menopause in their late 30s. I've seen that happen. If you've had a hysterectomy, that's a surgical way to go into menopause. So those are things to be aware of. It's not a bad thing, but what we do want to be able to do is if you've had a hysterectomy or you're in early menopause, we want to make sure that your hormones are balanced because you do get some significant benefit from estrogen, testosterone, and progesterone. Does that make sense?
Kind of.
Kind of.
I'm sure you'll keep talking about it. I'm just curious, like, would it be better to not have like all the craziness and just skip all of that and go into menopause?
For some women, yes. For others,
okay.
And you take that on an individual basis because there are pros and cons to going into menopause early. And so we can talk about that individually. We may talk about that a little more, but we'll talk about that. So early menopause is those that have had menopause occur before 45 years old. Premature menopause is those that have menopause before age 40. Now, there are some benefits to having estrogen from the perspective of blood vessel stabilization and brain function, and as well as progesterone levels at those as well. And so some women who have had premature menopause, or if you've had an ablation or you've had PCOS and you go into menopause early, then that may affect a number of things, which we'll talk about here in just a second. So keep that in the back of your mind. Both of these can occur because of what's called primary ovarian insufficiency, if I can speak. Autoimmune disorders can cause it, infection can cause it, genetic disorders, medical treatments like chemo or radiation, and surgery where you've had a hysterectomy. Those are things that can happen as well. My wife ended up having really bad. She had both PCOS and endometriosis, and so they took her uterus at age 40. So she went through the surgical part of that. One of the reasons I focus on hormones is I had to figure out what was happening with my wife because of her significant hormonal changes, because she had a total hysterectomy with both the ovaries and the uterus. And there are some significant problems if you have no hormones whatsoever. If you at age 40, so there's some rapid aging that can occur and things like that. So we want to make sure we can try to help you stay healthy and young as long as we can. That makes sense. So, and this is what I've been in practice for over 25 years now, 25 years roughly. Well, it's actually over 25 years. And what I've noticed over time in my practice is that there is a 30% drop in people's brain function when they become postmenopausal. So if you're postmenopausal in your 30s, late 30s or 40s, you start to see difficulty with function, with memory and cognition and focus and things like that. And that's a significant problem that affects a lot of women significantly. And so this is before menopause. This is an fMRI. It's an MRI of the brain where they use a radio labeled sugar, and where the blue is where the brain is it's quieter. And the red is where you see really hyperactive focus of the brain. So if you're, in this case, you've got a person in the MRI scanner and they're giving them, I think they gave them math equations to do or something like that, where they had them think and read, or they did something. And so the brain is functional. And so you see the hyperactive areas of the brain where they're very, very active. And this is before menopause. Now, this is the same person after menopause. And this can occur whenever that menopause occurs. But what you'll notice is that after menopause, same activity, you have less brain function that's occurring. And so that's significant. And some women feel it and some women don't. The challenge is that this actually can lead to dementia. And we see dementia arise because of this change that occurs. And so we're going to talk about that here. So your brain circuits are notably affected by this transition in menopause. You see effect on the hypothalamus, executive function of the brain, which is your ability to make decisions and hard decisions, sensory integration, ability of learning and memory, emotional motivation, your whole serotonin system, so depression, anxiety, panic, those all are significantly affected by this. Your adrenergic system, this is your adrenal glands. So these are all of these functions are affected when the progesterone, testosterone, and estrogen fall. And so those are things to be aware of. What signs can you see that if your brain is being affected by menopause? Well, hot flash. We used to just think, oh, hot flashes are a normal part of this, but they're actually not. Hot flashes are a sign that your brain is actually being affected by the shift in the hormones. And I'll show you why here in just a moment. Insomnia, depression, autoimmune disease, declining cognitive function, Alzheimer's, dementia. I think let me go back one. So all of these are signs that your brain is not happy with the change in the hormones. A lot of people don't realize that autoimmune disease flare up in the 40s and sometimes in the 30s, and this is often driven by a low level of progesterone or a change in levels of testosterone and estrogen. So a lot of what we've been told is normal in women is actually not normal, and it's a sign that the brain is starting to be affected and can increase the risk and potential for dementia. So white matter hyperintensities, these are, if we do an MRI or a CAT scan of the brain, you will see areas of the brain that show up with these white intensities. And this indicates that there's blood vessel risk and risk for stroke and worsening dementia and even mortality or death. And so let me show you what this means. So if you have moderate to severe hot flashes, those that have, let me see, so these are hot flashes at night. And so as you notice that as you have more hot flashes, your likelihood of white matter intensities go up. And so they're correlated, if that makes sense. So hot flashes are linked to increased risk of heart disease. So if you come into me saying, Dr. I'm having hot flashes, that tells me that you're laying down plaque in the smallest blood vessels and capillaries of your brain. And that implies that you may have increased risk. So this is the normal premenopausal brain, and this is a postmenopausal brain in a lady who had hot flashes. And you can see these white matter hyperintensities, which show up, which are actually indicative of a drop in estrogen significantly and a drop in progesterone. And this woman here is going to be at notably increased risk for stroke and other vascular diseases because of that. And the sign is that she's having hot flashes. Questions about that at all?
Well, what do we do about it?
Oh, you're leading us right down the road. All right, we'll answer that. All right, so let's talk. Go ahead, Lorraine. I'm sorry.
I just say I suffer from that every night.
Well, we want to fix it, and so this is one of the reasons I did this presentation was I realized even more that it's not just hot flashes, it is hot flashes that are putting you at risk for heart disease and stroke. And so we want to fix it for that reason. That's important. We have a little, you may hear a chicken in the background. Sorry, we've got a window open. It's got the chicken there nearby. All right. So in the main phases of midlife aging in the female, if you look at, there are 51 million women in the US between the ages of 40 and 60. 40 to 60 million women are premenopausal. 1.5 million women enter the perimenopausal phase every year, and the postmenopausal, and then the postmenopausal phase is after that. There is a decline in capacity for glucose metabolism that we see in women when you're experiencing a loss of estrogen. And what happens is a hot flash occurs when estrogen fluxes up or down, and that implies that there's a change in the way your smallest capillaries are functioning in the brain, and it changes the way your body can use glucose in the brain, and which then increases the risk of dementia, if that makes sense. So in these the cingulate cortex, the frontal cortex, the parietal cortex, medial cortex, lateral cortex, you actually see this change in the metabolism of glucose when estrogen begins to fall, and which is also causing your hot flashes, and is also increases your risk for heart disease and stroke. And I won't go into that heavily. I just want you to realize it affects the entire brain. So estrogen actually controls glucose uptake. It controls glucose uptake in the brain. So if you have no estrogen, that's bad. And one of the things I've seen when you have breast cancer is they suddenly put you on these estrogen blocker drugs that shut down your capacity to use glucose, which most of those women end up becoming pre-diabetic and diabetic, which then increases their risk for heart disease and stroke in the brain because of that. So insulin is the master regulator of glucose to use fat, but estrogen is the master regulator of glucose and fatty acid in the brain. So these two hormones are really, really important. And if your estrogen is way high, let me rephrase that. If your insulin is way high, you're going to see diabetes. And if your estrogen is too low, you're going to see abnormal regulation of fatty acids in the brain and glucose in the brain. So this is where the depression, the dementia, the memory changes, the other brain functions of fat are affected. Pardon me. The dogs in the background. Give me 1 second to make sure this is okay. All right, sorry about that. I had someone show up at my door and my dogs were crazy. So anyway, all right. Hopefully I didn't lose you. All right, so and let me think of where we're at here. So in the pre to perimenopausal range, you're somewhere between ages 20 to 40. This is the baseline MRI function. So you see the activity of the brain. 3 years after the perimenopausal spot, you can see these dramatic changes where there's been, let me rephrase that. So you got a 52-year-old woman, the average woman goes into perimenopause somewhere around 47, 48. So you can see there's a notable change in her function. Here's a 43-year-old woman who actually went into perimenopause early, or she's postmenopausal. So she went into menopause at around 40. You can see how dramatically low her brain function is here. This is a postmenopausal woman at 59. Again, you can see dramatic decrease in the brain function that's there. And then this is a male who's also 55. And you can see that because the male maintains his hormones, there's not a significant change in that brain function and brain capacity into the 50s. Questions about that? Okay. All right. We'll move forward then. Hopefully I'm not blowing you away with all these slides, but what I want you to see is that estrogen, progesterone, and testosterone are essential for the aging brain. That's really what I hope you gain from this. It is the master regulator of the neuronal bioenergetic system of the brain, estrogen is. So the decline in estrogen levels drives the decline in glucose metabolism during menopause. So one of the reasons I want you to have estrogen is because I want you to be able to maintain your brain's capacity to use fuel. And one of the causes of Alzheimer's dementia is that you don't actually have enough estrogen, which then doesn't let you use glucose, which actually amplifies the dementia, if that makes sense. So the human brain, despite it's only 2% of the body's mass, it consumes 20% of the body's fuel in its mitochondrial use and its ATP generation in its function. So your brain is using 20% of your energy loads, whether you realize it or not, even though it's only 2%. And it's important that you actually have fuel for that brain. So one of the reasons for shifting into a ketogenic diet is you're providing access to the brain with ketones instead of glucose even in the process of having your brain function drop. That's why I've had a lot of patients who do a ketogenic or carnivorous diet. We never change their hormones, but their brain function gets better because we're allowing them to access a different fuel rather than just glucose. They can access ketones. And so you're allowing the brain that's completely reliant upon mitochondrial function to have the fuel it needs. Instead of glucose, it can actually get ketones. Questions about that at all? Okay. All right. So the estrogen regulation of the brain, and you don't need to understand this, but essentially what I'm showing you here is that estrogen, specifically estradiol, plays a huge role in allowing you to access the substrates and generate the precursors to the getting fuel into the brain. It helps you use the fuel. It helps you create the enzymes that allow you to convert the glucose into pyruvate, and it also plays a role within inside the mitochondria in the actual production of ATP for fuel. ATP stands for adenosine triphosphate, and it's what allows it is the true fuel for every cell within the body, for muscles and for function and things of that nature. So your estrogen regulates every one of these enzymes within the mitochondria of the brain and other cells of the body. And this is why if you have no estrogen, you're notably more fatigued. And so one of the keys that's very essential is making sure we have enough estrogen and also enough progesterone, if that makes sense. Not that you have to memorize those slides. I just want you to realize how important estrogen is to the use of the mitochondria. So a lack of estrogen causes you to attempt to adapt while the white matter tries to provide other fuel for the brain. And one of the challenges, if you don't have ketones, then you start creating those white matter calcifications within the brain because the body's attempting to use fuel in that regard. It's attempting to break down fat. It's attempting to use part of the fuel. So it's essentially chewing on itself because it doesn't have enough estrogen, if that makes sense. So your brain starts to chew on its own little white matter, and you start to see those white matter changes, which then leads to the forms of dementia. Myelin debris activates the inflammation. You see oxidative damage, and you see neuron damage, neurons being the actual cells that let your brain communicate with the rest of your body. Again, this is another busy slide, and I just wanted you to realize that your body is using glucose to right here to function in the brain, in the neuron of the brain, and also in the microglia as well. You can either use ketones or you can use sugar, glucose, for fuel. Either of them work well, but if you have a challenge with your glucose and your estrogen low, having ketones available is actually really important. So number one, I recommend step number one in any of this process is follow a ketogenic or carnivorous diet. That's going to provide ketones for the brain, so you're actually going to do better. Number one. Number two, then we want to assess: are you deficient in your estrogen at all, so you can actually function correctly, and you won't form this white matter breakdown in the absence of the ketones, if that makes sense.
Is it reversible?
Say that again.
Is it reversible?
Yes, it actually is. I've actually seen it reverse. I have seen that. Yeah, it's not.
Brain.
You're thinking about the what?
The brain, the white matter in the brain.
Yeah, so that white matter is reversible. So if we start providing you substrates, your brain does heal. It actually does, and I've seen that happen.
Okay.
So, good question. Very, very good question. All right. What I want you to realize when the negative effects of menopause are primarily driven by a dysregulation of estrogen signaling in the fatty tissues. So when you have estrogen low, you see all of these levels, all of these things increase, and you see a change in the regulation of the hormones. I'm going to remove this. It's in menopause. If that makes sense. Aurora raised her hand. Aurora, let me make sure. Did you have a question, Aurora? And I may need to see if I can let you talk. Somewhere in here, I thought your hand was raised, but let me see. Let's see. I'm turning on. We had some other people join, and Aurora, I don't see you on the list here. Maybe she stepped out. Oh, there she is. Aurora, did you have a question? I'll let you.
Okay, I do. I do.
Yes.
Everything that you're talking about, is there a correlation with the thyroid? because I know that with my hormones, where there a disbalance with my hormones, you mentioned about my thyroid, and then so is there a correlation with all of this?
Yes. So let me back up and give you the 30,000-foot view. What I find is this, and over my years of practice, what I found is if I don't fix the diet first, no matter what I do to the thyroid or the female or male hormones, it doesn't work. So if you fix the diet, then the next step is to fix the thyroid. If your thyroid's off, it doesn't matter what female hormones I give you, or if I modify your hormones, it won't make a change in your metabolism. So I have to fix the thyroid second. So if we want to get the thyroid balance, number two, because the thyroid does affect the way your body metabolizes and creates hormones. So if your thyroid's off, we got to fix that first, or the hormones will always be out of whack. So we fix the thyroid second. Third, then we fix the female hormones and the male hormones if we need to. So it is correlated, absolutely. But I find that you've got to fix the thyroid first. And what I commonly see is if your estrogen's off, it's going to amplify autoimmune disorders like Hashimoto's in the thyroid. They're going to be amplified.
Okay.
Hopefully that answers your question.
No, it does. And that's what you're treating me for. Does it take a long time for this to find a balance, or it takes
usually
like
within 2 to 3 months? Usually within 2 to 3 months, these will balance.
Yeah.
But the important thing to understand is that as a person is moving in from perimenopause into menopause, these hormones begin to fall. So we're kind of chasing a moving target. And so a lot of people
I'm already in menopause. I'm 70 years old, so definitely I am in menopause.
But even then, I see these hormones fall further. So over time, you're gonna see falling. So a lot of people get upset and say, "Why am I not fixed yet?" Well, what we're doing is we're chasing a moving target, and and so we modify the hormones. It takes about 2 months for them to balance, but then the target's moving because your ovaries are slowly decaying, they're aging, and they produce less and less. And so we got to fix the diet, we fix the thyroid, and then we're trying to chase a moving target with hormones. And that's where a lot of doctors hate to work with them, because they're not easy to manipulate or to try to fix. Does that make sense?
Yes. No, it does. Thank you.
Yeah. So I asked my wife, I said, if I talk to women about hormones, what should I tell them? And she said, be very, very patient. It takes a while to balance the hormones. And and she has no hormones. And even in her case, because she's getting older and her body ages, we still have to chase those hormones. There's still effect there.
Okay.
Good question.
Thank you.
All right. If we put you on a hormone, you see less weight gain, less fat gain. We see beneficial effects on insulin. We see type 2 diabetes is better controlled. We see leptin is better controlled. Ghrelin is better controlled. We see improvement. We don't know if it affects adiponectin much, but there's significant benefit on the use of sex hormone binding globulin, which is a binder that lets you. So when a hormone is put in the body, you have free hormone, and we have hormone that's bound to sex hormone binding globulin. And what happens is it actually lowers the sex hormone binding globulin, so your hormones are more sexually accessible to you. So if you are in menopause and we don't treat it, you'll see this group here. If we treat it, you'll see improvement with this yellow range here. And I realize it's a busy slide, but hopefully that gives you some idea that we want to get the diet under control. We want to get the sugars under control. We want to get the thyroid in control, and then we want to modulate the hormones if they haven't been fixed, I should say. So postmenopausal women have higher chronic levels of inflammatory cytokines like tumor necrosis factor alpha and interleukin 6, and they see reduced ability to respond to infections because of that. Tumor necrosis factor alpha and interleukin 6 are the two hormones that are really high in insulin resistance. They're really high in COVID, and when these are high, it's harder to treat those infections. So as the fat cells get bigger, they're also sicker, and that fat cell produces high levels of TNF alpha and interleukin 6, and you see poorer responses to infection control, poorer responses to healing from illness, poorer responses to inflammation, things like that. So that's why having estrogen, progesterone, and testosterone in the body is essential. Questions about that at all? All right. As you have these high levels of these two hormones that come from the fat cells, one reason is because the fat cells may be large because you're overweight, or it may be because you have low estrogen levels. This leads to what's called microglial debris, breakdown of the small neurons in the brain, early death of those neurons and early death of the immune cells, which then puts you in significant susceptibility to viral infections like COVID and things of that nature. And that's what we commonly see that with people. So a lot of people say, well, why do I also have harder time getting over illness? And then part of the reason is being overweight or having low female and male hormones. So the severity of your hot flash is associated with these following mediators. You see subclinical heart disease. We see increased cardiovascular risk. We see small vessel disease in the brain. We see Alzheimer's dementia. We see white matter ischemic disease, and we see stroke and cognitive decline, and we see autoimmune changes. These are the research articles that go with the fact that as your estrogen's falling, you're having greater degree of hot flashes. That's a sign that all these things are happening. You're starting to be at greater risk for heart disease, Alzheimer's, dementia, stroke, and autoimmune disorder. So one of the reasons to check your hormones and modulate them if we need to. Women have twice the risk of Alzheimer's dementia. And the reason why is that the drop in estrogen, they have lower brain glucose metabolism, and then they have adaptive cellular response, which means they have a fall. As estrogen falls, there's an increased level of CD4, which is a tumor marker, and then you see an increased production of tumor necrosis factor alpha, insulin-like or INF gamma, and interleukin 1b. I won't dive into all those, but essentially you see worsening immune system, worsening dementia, and worsening risk of heart disease, which puts you at twice the risk of Alzheimer's dementia. These amyloid plaques develop and neurofibrillary tangles develop, and it's often related to not just it's related to low estrogen, and you see a greater deposition of these tau proteins in women and that are similar to men in the amyloid deposition and tau proteins, and these are two different forms of plaques in the brain that we've noticed for years with Alzheimer's dementia, but we haven't understood why, if that makes sense. And now we know that estrogen plays a significant role there. Let's see, this is a busy slide here. Let me go back. Let's see. So what happens is as your glucose metabolism falls off in the brain, so we know estrogen falls, then your capacity for using glucose in the brain falls. So then you have to start using fatty acid breakdown. And if you're not providing yourself enough fat and protein, this won't happen. You see what's called innate immune response has to flare up, and we see adaptive immune response. So what happens is your immune cells start to flare up, and this is where the autoimmune disorder comes from. This is where the increased risk and susceptibility to infections, bladder infections, other types of infections kick in. And as estrogen falls, and as the cells of the brain begin to die, we see in a lot of women the increased amyloid deposition and increased inflammatory expression, if that makes sense, which all leads to an increased risk of dementia. Questions about any of that?
What about stress with the brain and the hormones and all that kind of stuff? I'm referring to my husband passed away last year.
Yeah. Well, your capacity to handle stress is dramatically suppressed. Okay. I may have a slide showing the sex hormones, but your capacity, remember your body uses progesterone and DHEA to handle stress and make cortisol. And if you're low on progesterone and low on DHEA, you're not going to handle stress well, which is going to add to general inflammation as well. That's a broad general answer, but I see that constantly, Lorraine.
Okay.
Very
Thank you.
common. No, that's right. All right. This is a slide. I'm trying to remember what we were seeing on this one here. Let me go back here. So there's an association between endogenous estrogen and gray matter volume. So what happens is there's gray matter volume goes up with the use of hormone replacement therapy. So this is a person's brain scan with fMRI showing the volume of gray matter before they were on hormone therapy and after they were on hormone therapy. So because of estrogen decline and testosterone decline, progesterone decline, we see a loss of gray matter. To answer the question I think you had, Lorraine, earlier is, if I treat it, is it reversible? And you can see, yes, it's dramatically reversible. You can see the difference between the brain function here and here specifically, and along the outer walls of the tissue of the brain, when we just give you back your hormones, if that makes sense.
Right. Right.
So this is the take-home message. Number one, follow a ketogenic or carnivorous diet. That's going to give you fuel for the brain. It's going to give you adequate ketones and not make your brain so dependent upon glucose. Second thing, I would probably put in between there to answer Aurora's question. We want to make sure the thyroid is balanced. That's important to make sure that's balanced, because if we don't balance thyroid, nothing we do with giving you estrogen, progesterone, or testosterone is going to help. So we want to make sure the thyroid's under control. Once we know that that's under control, then we want to monitor estrogen, progesterone, and testosterone. Now, you may not need them, or we may find that using them may be helpful for you. We want the estrogen progesterone ratio to be balanced. It's important to give you estrogen, but too much estrogen is a problem, and too little estrogen, as you've seen, is a major problem. And the problem with not having enough progesterone in the ratio of estrogen means you're going to still see significant aging, and you're going to see poor sleep and poor concentration and poor memory. Progesterone plays a huge role in memory. And so that's important to balance that estrogen progesterone ratio. That makes sense. We take your progesterone, we multiply that by 1,000, and we divide that by the estradiol, and that gives you a ratio. That ratio should be somewhere between 100 and 500. And we calculate that in the office each time we check it. And so what I'll do is I'll often check your hormones every 3 to 6 months to make sure that we have that ratio balanced, if that makes sense. Now, you may have risks, and a lot of people want to have their blood test and testing for the ApoE4 test, which is a precursor gene that may predispose you to dementia. And the reason this precursor gene is present means that you're much more sensitive to a lack of estrogen, essentially is what that means. And so if you have this precursor, then the treatment would be ensure that your estrogen progesterone ratio is balanced. That's really what I'd recommend there. All right. That's it. Any other questions?
Nally,
Yes, ma'am.
do you do this test, the ApoE4 at your office?
I can order it, but I don't do it a lot, because a lot of times when I order it, it just adds more stress, because you now think, oh my gosh, I'm at risk for dementia. And your risk is there not because of the ApoE, it's there because your hormones are off. And so I don't often check unless someone has a family history of dementia. If they do, then I can check it. But having it present, if you know, hey, it's like me checking for your risk for breast cancer. Your breast cancer is going to be there if your estrogen progesterone ratio is high or low, I should say. But telling you, hey, you're at twice the risk of breast cancer just adds to your stress. I don't necessarily know if that's important or not. Some men or women think it is, and others don't. I personally say, why? If you, it's kind of like saying, do I have a gun in my pocket or do I not have a gun in my pocket? Whether the gun is loaded or not, and whether you're going to use the gun is not important. It is important. It's not whether you have the gun. Does that make sense?
Yes. No, and another question I have, estradiol, the cream, is that to work together with the progesterone?
Yes.
There's a cream, vaginal cream.
Yes. So let me explain. There is one form of progesterone that's bioidentical, and it's called progesterone or micronized progesterone. There are three. Pills, right? Yeah, those are pills usually. There are 3 forms of estrogen: E1, E2, and E3. There's estradiol, estrone, and estriol. We look at estriol and estradiol, but we don't necessarily look at estrone, because when you have enough estradiol or I'm confusing myself. When you have enough E2 and E3, which is estradiol and estriol, then you're going to make enough estrone naturally. So, and I don't have the slide up here to show you, but estradiol, which is E2, and E3, we will usually use in a cream form or in a pill form. We can either compound it, or you can use it as a cream. We can use it in a pellet form. There's a number of forms that are there. We found that estradiol is the most easy to supplement, and it will make the other 2 hormones very simply. So the easiest to supplement is the estrogen, or I'm sorry, the estradiol, which is one of the 3 estrogens.
Okay. Yes, thank you.
Does that make sense?
Yes, it does.
Yeah. So we can supplement hormones by either topical, oral, pellets. Those are the 3 ways to supplement those hormones.
And they have the same results?
They do. Okay. Creams are not as effective as oral pills or pellets, if that makes sense.
This is
I hear somebody in the background. Anyway, okay. Any other questions I can answer?
I have fallen off the wagon since my husband passed.
Okay.
And so I'm up 30 to 40 pounds. Do I need to come in and get tested again? I mean, I've got progesterone, estradiol, and thyroid med.
So if you can get back on the wagon and start on the process and the weight starts to move, then you're great. If it's not moving, then we do want to check those hormones.
Okay.
That makes sense.
Because I haven't seen you since December, which
Yeah.
a year ago
Yeah.
December, and that was when he passed. So
Yeah, if you're not seeing the change in your diet affect you, then we may want to adjust those hormones a little bit further to help with that. That makes sense.
The hot flashes are getting really bad. So
Then then are you on the hormones then?
yes.
Then if they're bad, then see if the diet changes. If it doesn't, then we got to fix the hormones. Yeah.
Okay. I appreciate that.
Yeah. All right. I saw a hand with Wendy. Wendy, did you have a question?
I just joined late and I wanted you to unmute me, but yeah, so not right now. Let me think.
Okay. Yeah. Okay. All right. Well, thank you. All right. Any other questions I can answer? You guys are great questions. Hopefully,
are you at the end? Is this the end?
This is the end. Yeah, this is the end.
Oh, okay.
Yeah.
Okay. Because I lost track of time. Sorry.
No, that's all right.
Dr. Nally?
Yes, ma'am.
Yes, I have another question in regards to do hormones, when they start balancing, do they lower your blood pressure?
To some degree, I've seen it. I've seen your blood pressure normalize, not lower it to an abnormal level. No, I don't see it dropping to abnormal, but I see it. But if you're on a blood pressure medicine, you might not need a blood pressure medicine as much. Yes.
Well, and the reason I'm asking, because since I've been in hormones, like I would say probably more than 6 months, under your direction, my high blood pressure is, I always had 40, 150, 100, over 140 and up. So lately, since December, I've been noticing that it's been dropping to 130, 120 over 80. So, and I have not seen these numbers for years and years and years. So that was my question.
My suspicion, Aurora, is that it's a combination of everything.
Okay.
Because insulin is the biggest driver for blood pressure.
Oh, okay.
But estrogen does play a role, and so if we balance your estrogen, then we will see some improvement in blood pressure to some degree.
Okay.
I've not seen a large amount of it, but I have seen some.
Thank you.
You're welcome. All right.
Thanks.
Any other questions?
Yeah, another mutual patient of yours, a friend of mine, she's thinking that the oral progesterone is making her bloated. Is that possible? Because you told me it would help lose the weight around the middle and all that kind of stuff. So
there's a difference between bloating and weight gain around the middle. It's gonna control the bloating. It's gonna control the weight gain around the middle. Too much progesterone could make a person feel bloated, and I've had a few people who used the pharmaceutical grade progesterone experience some bloating where they didn't with the compounded version. Both are bioidentical, but depending on what they use as a binder, that may cause them to bloat. I have seen a couple patients with that happening, and in those cases, we've switched it to a compounded olive oil base, and it seems to work better.
But you wouldn't know without testing, right?
I would need to test and see. Yeah, the first problem is a lot of people think it's their bloating is coming from their progesterone, and what's happened is their estrogen spiked, and the high estrogen will cause bloating for sure.
Okay.
Well, if everything else is balanced perfectly, your diet is balanced perfectly, you're not cheating and not eating a bunch of crappy garbage or sweeteners that make you bloated. I commonly see people switch up their diet and use sweeteners, and that causes them to bloat, and they think it's the hormones. But as long as the other pieces are balanced, what I normally see with bloating when it comes to hormones is either the estrogen is too high or their progesterone is way too high and they have no estrogen. And so those are the two common side effects of where I see bloating from progesterone or estrogen. But the only way to know is to test the hormones.
Okay, got it. That's helpful.
Good questions. All right, you guys. Any other questions?
I had just one more. I was listening to another podcast, and one of the things they were talking about was you referenced bioidentical versus the horse urine version of the estrogen. And the point that this person was making is that they're more familiar with how the horse urine version, and it's been tested and all that kind of stuff, and you can still have problems on either one. What is your opinion on that?
So my opinion comes from my clinical experience. That's what it comes from. I've used both. I was trained to use the synthetics. The synthetics work, but I always see side effects. The risks for breast cancer and ovarian cancer and other forms of cancer are much higher. Blood clots are much higher with the synthetics. I see much less risk with the bioidenticals. I've used bioidenticals with patients for 15 years as a primary source. I have found dramatically less risk and better tolerance all around the whole spectrum with the use of bioidenticals. So I predominantly recommend bioidenticals. In fact, I refuse to write synthetics because the risks of cancers are high with those, but they're not with the bioidenticals. Did that answer your question?
Yeah, maybe I don't understand what bioidentical means.
Okay, so
definition.
So bioidentical means that if you were to take your real estrogen and a estrogen that's bioidentical, and you look at it under a microscope, they are exactly identical. Exactly identical. Now, a bioidentical, exactly identical hormone cannot be patented, meaning you cannot patent it as your own and charge a twice or 5 times the amount of money. So there's no profit with the pharmaceutical companies in making those hormones. The synthetic form of progesterone is called progestin, or medroxyprogesterone. And there are synthetic forms of estrogens called there's 3 of them, and they're levonorgestrel and norgestrel, and there's ethinyl estradiol. Those are synthetics, meaning there's one little molecule different on those hormones than the original hormone in your body makes. So those are synthetics. Bioidenticals are, now let me clarify, you got to make the bioidentical hormone some way. You got to derive it from something. So there is some processing to make that bioidentical hormone, but when its end product, it is identical molecularly, if you look at it under an electron microscope, to what your body makes. So it's called a bioidentical hormone for that reason. There is synthetic processing that occurs, but it's not the end component of that hormone is not different than your original hormone your body makes.
So this is something that can be put together scientifically. I'm like, what is the catalyst that makes this? I mean, where you got the pharmaceutical.
So they can make them from plants. You can use horse urine to derive some forms of them, but they then have to process out the other components that may be there. There's
it's a chemical compound.
What's that?
It's a chemical compound.
It is a chemical compound to start with, yeah, and you're using a lab to derive the final product, but the final product is identical to what your body makes. It's no different.
Yeah. Okay, that makes sense. Thank you.
Yeah, so hopefully that's clear. And if you look at the studies that compare the effects of bioidentical hormones to synthetic hormones, then you will see that they do very well. That they do much better than the synthetics do. Now, if you want to understand all the nuances behind that, the book that I just wrote that's available on Kindle has a whole chapter on what's the difference between synthetics and bioidenticals. And you can buy it on Kindle. What's that? I wrote a new book. Yes, I wrote a book called The Menopausal the Menopausal Survival Guide. And you can find it on Amazon, on Kindle. Just type in Menopausal Survival Guide, Adam Nally, and it'll pull right back. It'll pull up for you.
Right.
$10. It's $10 on Kindle. I don't have a hard copy yet. I've been trying to find a printer that won't charge me an arm and a leg. But yes, it's there.
Okay. Hey, that's helpful.
It will dive into this much deeper. So I'd say for sure get a copy of the book. Because
I'm a very sciencey type person.
You would love it. And now you can also get it from a PDF version if you go to my website. It's on my website and you can download the PDF version. I have that on my website as well. So either there. Yep. Sarah, did you have a question?
I do. I don't think I've ever had a hot flash. Would I know if I've had a hot flash?
Oh, you'd know it, yes.
Oh, yeah.
Ask all the other women on here. Yeah.
Okay. Well,
if you sit in a group of women and you say, "What is a hot flash?" Believe me, you get an earful.
Okay, well, I have like all the other symptoms, but I think I have all the other symptoms from PCOS, not from going into menopause.
Yeah.
So that's why I'm like, well, maybe I've had one and I just don't know. But
You would know. I guarantee you'd know. Yeah.
okay, well, I'll be 45 this year, so I'm at that age.
You're at that age where you might start seeing them, but you might be one of those lucky ones that never has them.
Yeah, because
I have a few gray hairs popping up that I'm like, oh no, that's not okay.
So that's progesterone, yes. All right. Any other questions?
no. Are you planning on doing this weekly?
I do this every week for the Keto Clan group. So if you're a part of the Keto Clan, this is one of the things we do every week. I've opened it up to the public a couple times just because I thought it would be interesting for those to hear. So like we did the cholesterol topic last week. We did the hormones this week. Those are two big topics that I thought my patients and others that are listening may want to listen to. But we do a topic. We rotate through 28 different topics right now, and I as new things come along, I add more topics. So the direct primary care is one program. Yes, the Keto Clan is a step up program where there's a whole slew of self-learning modules on the membership site, and we do these Keto Clan weekly talks.
Okay. Well,
Did you get any new members after last week's topic?
I had two. Yeah, Heather, I had a question. I see Heather's hand up.
Are the night sweats hot flashes?
Yes.
Oh, great. Okay.
So what happens is a lot of women will describe them as a rush of heat in their upper body, often and sometimes the whole body. I have someone that's so bad that they actually will drench their shirt or nightgown and have to change 1 or 2 times a night, sometimes 3 times. So they can be significant in severity or less. But the night sweats are related to estrogen fluxing, yes.
Yeah, I have to change my shirt once. I'll see you in a couple weeks.
Okay. I look forward to having an estrogen talk with you, Heather. All right. Any other questions? Great questions, you guys. Thank you.
Thank you.
All right, then we'll close up. We'll see you next week, and we'll go from there. You guys have a great evening, and we'll talk to you soon.
Good night, everybody.
All right, guys. Good night.
Good night.
Good night.